Okay. Good evening, dear students. Today, I'm here to discuss about the previous INI SS questions. And the topic assigned to me is colon, rectum, and anus. This is 2 years question paper. I went through the June paper as well as the last year's October paper, but I could hardly find only a few questions coming from colorectum. So very few questions, but I have enumerated the questions as well as the detailed discussion of those questions. Without wasting much time, let's dive into the session. So, which of the following statements regarding large bowel obstruction is not true? So the options were closed loop obstruction can be seen in the absence of colonic volvulus or strangulated hernia. Second option, in USA, most common cause is colorectal carcinoma. Option C, colonic volvulus includes more than half of the cases of the causes of the large bowel obstruction. Option D, volvulus is more common in Africa, Asia, and India, where it comprises the most common cause. Now, so this is basically all about large bowel obstruction, and I could see the examiner clearly taking it from the first 2-3 paragraphs of your Sebastian 21st edition. So the large bowel obstruction, as you all people know, the most common etiology differs region wise. In United States, it is the colorectal cancer causing large bowel obstruction, which is the most common cause there in US. Here in the European countries, the African countries, the Middle East, as well as the Asian countries, including India, we got the volvulus, the colonic volvulus being most common etiology causing large bowel obstruction. So worldwide, it will be the colonic volvulus which causes which is the most common cause of large bowel obstruction. If at all in volvulus, you want to, if they ask which is the most common site of volvulus, it's a sigmoid volvulus. Now, all this volvulus and some conditions like strangulated hernia, where you can expect a closed loop obstruction. That is, the proximal segments of the colon as well as the distal segments, they are blocked. That is, the one part of the intestine is trapped and by either cause like volvulus or a strangulated hernia or an obstructed colon cancer with an competent ileocecal valve, where such condition occurs, the proximal as well as the distal segments are of this segment is blocked. So what happens is, sorry. So what happens is, you encounter a condition where there is a dilated proximal bowel as well as there being dilated proximal bowel and a decompressed distal bowel. So what happens is this segment has got all the potentials for going into ischemia or perforation, thereby causing rapid deterioration of the patient. So where all this volvulus or where all this closed loop obstruction occurs, it takes place in conditions where the segment of the intestine gets entrapped, like volvulus, I said, strangulated hernias, as well as the obstructing colon cancer with IC valve, competent IC valve. And here is a diagram which I have taken from Sebastian. This is the sigmoid volvulus. Characteristic bent inner tube appearance is found. And if you take a CT in this patient, you will see the mesenteric whorl. The mesenteric whorl is nothing but due to the excess torsion, the characteristic mesenteric whorl occurs, and it is always ideal to intervene early in these cases of closed loop obstruction caused by either volvulus or strangulated hernia or colorectal cancer, where there is a pressure on the mesentery which can compromise the blood supply. Like if there is this mesenteric whorl, there is a pressure on the mesentery which can compromise the blood supply, initially obstructing the venous return and thereby increasing edema and inflammation, eventually occluding the arterial blood supply also, thereby causing resultant ischemia. With ischemia, there occurs further necrosis and perforation, and that is why patient will land in emergency to you when you have not intervened at proper time, proper condition, situation of all this volvulus causing a surgical emergency. Now, so this is the question which is tackled here, the etiology part. And I also told you about the characteristic X-ray appearance and why to intervene in case of closed large bowel obstruction. Now, coming to the so in here, coming to the option, closed loop obstruction can be seen in the absence of volvulus or strangulated hernia. Not so. This is the most two common conditions where you can see closed loop obstruction. If at all, one other condition is where you have got a colorectal CA with a with an incompetent ileocecal valve. If the valve is competent, with a competent ileocecal valve, the valve is competent, it is going to cause a closed loop obstruction. Okay. And the other options in USA, the most common cause is colorectal carcinoma. Yes. Colonic volvulus includes more than half of the cases of large bowel obstruction. Yes, we saw in European countries, in African countries, and Asian countries, you get the volvulus being the most common cause. And that is what given in the D option. It is more common in Africa, Asia, and India. So answer is A. This is a straight question from Sebastian, and that's what we have seen. Now coming to the next question, which of the following statements regarding HNPCC is not true? Option A, predilection for right-sided tumor with synchronous and metachronous lesion. Option B, older age of presentation. Option C, it is an autosomal dominant mutation and then a defect of MMR gene defect. So option D is overall lifetime risk in male is 70% and female is 40%. Before diving into the question, this is also a question which is taken directly from your Sebastian 21. I could see the examiner just taking line by line from Sebastian. So as per the Lynch syndrome is concerned, it is an autosomal dominant disease comprising of almost 3 to 5% of colorectal cancers, and it constitutes about 15% of familial colorectal cancers. And the DNA mismatch repair gene, MMR is the gene defect here. And this forms the microsatellite instable MSI gene, that is microsatellite instability. And 10 to 19% of the colorectal cancers are diagnosed before age 50 years. So what we need to ask here in all these patients is a detailed family history. But again, 10 to 20% are caused by spontaneous germline mutations also. And there are two types. One is Lynch 1, second is Lynch 2, where there is colorectal cancer alone is Lynch 1, and when there is associated malignancy along with this is Lynch 2. Now, all this MSI microsatellite instable gene is found in mutation is found in most of the colonic malignancies in Lynch syndrome, almost more than 90%. So if you do an immunohistochemistry for this MMR gene using antibodies, you can evaluate for the loss of the mismatch repair gene expression, that is loss of MMR gene. That can assist you in identification of the patient with Lynch syndrome. Now, with this MSI colorectal cancer, you have to identify whether it is a Lynch or it is a somatic mutation. For that, you need to do only one test to differentiate it from Lynch versus somatic mutation. You have to check for the presence of BRAF mutation. This we have already seen in classes. If there is presence of BRAF mutation, then it is mostly a somatic mutation, like 15% of the sporadic colorectal cancer. The absence of BRAF is an indication that it is a Lynch syndrome. So in all these patients, the estimated lifetime risk of colorectal cancer is 70% in male, 40% in females. Age of presentation when compared to sporadic CA, it is like around 45 to 60 years when compared to 69 years in sporadic colorectal cancer. Okay. And okay, and that is why we have what we have got the option there where it was mentioned that there is 70% lifetime risk in males, 40% lifetime risk in females, and another option was older age of presentation. No, it is controversy that the diagnosis of Lynch syndrome, the mean age group is younger age group, which is more affected in Lynch when compared to the sporadic colorectal cancer, which occurs in older age. Now, coming to the Lynch syndrome, the site of cancer in Lynch syndrome is that the tumor has got a common presentation of a prediction for right-sided colon cancer. And if you see the histology of the tumor, it is a poorly differentiated tumor with mucinous and signet ring cell histology, and the tumor infiltrating lymphocytes and lymphoid host tissue responses present. Now, What else is the common presentation apart from right-sided? With right-sided, it can occur at different sides of the colon and rectum, thereby presenting as a synchronous lesion or either or only a left-sided colon cancer or only a rectal cancer. Now, in Lynch syndrome, you have to do mostly a total colectomy. It is because any treatment less than total colectomy, the patient has always got the chances of getting a risk of metachronous colorectal cancer. The risk of metachronous colorectal cancer, if you do any treatment less than total colectomy, if you go and do a right hemicolectomy for a right side lesion or a subtotal colectomy or a left hemicolectomy, the risk of metachronous colorectal cancer that is developing at other sides within 12 months, that is the risk of metachronous lesion is within 10 years is around the order of 16%, and within 20 years it is around 40 percentage. So, and within 30 years it is around 60%. I used to remember 20, 40, 60, 10 years, 20 years, 30 years. So no treatment less than total colectomy should be undertaken in cases of patients with Lynch syndrome. So that is all about Lynch, and with this we can able to identify which is the wrong statement. I already gave a clue that it has got a predilection for right-sided tumor. Yes, of course, with synchronous and metachronous lesion occurring. Yes, yes, that is a true statement. It is an autosomal dominant mutation with a repair in the mismatch repair gene defect, that is MMR defect, and overall lifetime risk in male is 70% and female is 40%. But the wrong option is older age of presentation. It is not old age, it is a younger age of presentation. The younger age of presentation is what separates Lynch from when compared to colorectal sporadic CS. Okay, so the answer is B, and this is a straight line taken from Sebastian. Now, coming to the third question, it is this question I could search from Sebastian, but I couldn't get the reference. It is taken from Shackelford. So, what he wants to know is when do you don't do stricturoplasty, especially in cases like Crohn's? So, which of the following regarding principles of stricturoplasty is not true? Is it multiple short strictures? Is it long segment stricture of 20 centimeters? Is it low albumin or stricture involving substantial part of the intestine? For this, you have to know the concepts of you have to know the typical concepts of or the colonic stricture. So first of all, you need to know that the strictures and bowel obstruction is the most common surgical indication in a Crohn's disease. Almost every in 20 years of the disease course, 60% of the patients almost develop either stricturing or penetrating disease. And the majority of the strictures, they are fibrotic strictures, while minority of the strictures are inflammatory type of strictures. So fibrotic stricture has nothing but apposition of extracellular matrix and all that, causing a fibrosed stricture in Crohn's disease. So now what are the management options for stricture in Crohn's? So once a stricture is formed causing a typical bowel obstruction picture, so you have got either endoscopic managements or surgical management. Among the surgical managements, you have got either surgical resection or stricturoplasty. Various trials all around the world have showed that both carry the same morbidity and the recurrence rates of almost 25% when carried out. So both morbidity and recurrence rates are similar when compared to stricturoplasty and surgical resection. Now, now you need to know where do we do stricturoplasty. So this is taken from Shackelford, this line by line from Shackelford, where they have discussed the indications of stricturoplasty in Crohn's. If at all you encounter a Crohn's where the patient has already undergone a resection, surgical resection, where more than 100 centimeters of the small bowel has been resected, then you need to go ahead with stricturoplasty in this patient. And suppose if the patient is suffering from short bowel syndrome, or if the stricture disease is involving a substantial portion of the intestine, then you need to do stricturoplasty in this patient. Now, what are the contraindications of stricturoplasty in case of Crohn's? Say, suppose if there is stricture and that has perforated, then you need to go ahead with surgical resection. So any complications like perforation, associated fistula, adjacent phlegmon, and if you suspect malignancy in Crohn's stricture, and then you go and try to resect. Now, one important factor is when the patient has severe preoperative malnutrition. Okay, so that is a contraindication for stricturoplasty in Crohn's disease. Now, I thought I would discuss all the types of stricturoplasty also. This is the most commonly done stricturoplasty where you open it by a longitudinal anti-mesenteric insection and close it transversely. This is the Heineke-Mikulik stricturoplasty done for strictures of 5 to 10 centimeter in length. Now, coming to the strictures which are 10 to 20 centimeter in length, what you do is you do a longitudinal enterotomy along halfway between the mesenteric and anti-mesenteric border, and then you anastomose here. Like it forms a side to side, but an anti-peristaltic enterostomy. That is nothing but the Finnish stricturoplasty, where you do it for strictures for 10 to 15 centimeters in length. Now, coming to the other techniques, non-conventional techniques, but followed for strictures more than 25 centimeter in length. And here is a picture of the most commonly performed procedure where we have performed a side-to-side isoperistaltic enterostomy. This is nothing but the Michelasi technique. Michelasi stricturoplasty done for longer strictures more than 25 centimeter in length, and you're done in a side-to-side fashion. So these are all the indications for stricturoplasty. Now that I said already, what are the indications for surgical resection? If at all you have patients associated complications with stricture, like that of perforation, fistula, phlegmon, malignancy, then you obviously go for surgical resection. But you have to have this in mind that both the procedures, stricturoplasty and surgical resection, carry the same morbidity and recurrence rates when compared head to head. Now, what other option do the patient has? Now, the other option of surgical technique is doing an exclusion bypass of the affected segment. This is not much followed because of the reason that if you exclude and do bypass of the segments, what happens is the segment which is excluded tends to get affected with CA, and the incidence of adenocarcinoma in the excluded segment in Crohn's is common when you try to do an exclusion bypass. Again, what are the indications of endoscopic balloon dilatation? Endoscopic balloon dilatation indications are, so if the stricture is endoscopically accessible, and if the stricture is non-angulated and less than or equal to 5 centimeter in length, and there is no associated complications like fistula, abscess, phlegmon, malignancy, then you have got endoscopic balloon dilatation. We do in our hospital where there is a single stricture, non-angulated, less than 5 centimeter, short segment stricture, and you can give a trial of endoscopic balloon dilatation. Okay, and one point I want to tell is that once you do a stricturoplasty, then you try to run the segments to and fro and then check whether stricturoplasty has been effective or not. So with this idea in background, what we come to this question is that they are asking which is not true. Where do you do not do stricturoplasty? So multiple strictures, short strictures you can always do. Long segment strictures, because you can't go and do resection. You can't, the patient will land up in small bowel syndrome, short bowel syndrome, and a substantial part of the intestine, it is an indication for stricturoplasty. And if there is long segment stricture of 20 centimeters, I said various techniques, non-conventional stricturoplasties like the Moscow Vasque Newmar and the Michelasi technique, which is most commonly used, has been side-to-side isoperistaltic stricturoplasty has been followed. Okay. Now, if the stricture is involving substantial part of the intestine, that is forms one another indication. But I said if the patient is developing preoperative low albumin malnutrition, then you have no role of stricturoplasty in that patients. So we tend to yield to this option because we think that surgical resection is not indicated in such cases, and so we can do stricturoplasty. No, so stricturoplasty, one such contraindication is low albumin or severe preoperative malnutrition. Okay, that you have to keep in mind. So answer obviously is option C, and this is taken from Shackelford. Now, one another question from Shackelford, just to the next chapter they have taken. It is nothing but how will you manage the Crohn's disease? Here we couldn't get the all the four options from the students who attended. So I have probably designed a question, and there is the latest edition of Shackelford also tries to check you with this. So the options may not be exactly that of the question which was asked, But what we try to intend to teach here is the concepts. So, which is not true. If the in case of medically refractory disease with rectal sparing, so you have a medically refractory Crohn's, and in that patient, the rectum is not involved. You can do a total abdominal colectomy with ileorectal anastomosis. That is the first option. So in case of medically refractory Crohn's with rectal involvement, okay. So all these options question is all about medically refractory Crohn's. So if there is rectal involvement, total proctocolectomy with ileorectal with end ileostomy is done. I'm sorry, this question is wrong. End ileostomy is done. It's not ileorectal anastomosis. End ileostomy is done. So that is also correct option. So now there was another option, like two options here. We are not sure what the options were actually. Top-down therapy with antibiotics followed by diversion. If no response, then surgery. Now, top-down therapy with antibiotics followed by diversion and continue the therapy. Okay. So what we try to get a picture of here is he was literally checking you whether you have read Shackelford or not. So what Shackelford says, even the new edition, what it says is that, see, in cases of what are the indications for surgical management in Crohn's? So any medically refractory disease forms a cornerstone of surgical management in Crohn's disease. Any complication of Crohn's, like if there is obstruction, fistula, abscess, bleeding, complex perianal disease, perianal Crohn's, and if there is growth impairment in pediatric age group, or some less common conditions like free perforation, acute fulminant colitis, or uncontrolled sepsis, you have got surgical option as the prime management of treating Crohn's. Now, what I wanted to highlight here is, see, in surgery for isolated colonic Crohn's, if the patient comes in emergency condition like a fulminant colitis or a toxic megacolon, you are going to do a total abdominal colectomy and end ileostomy and bring down the rectal stump, either do a Hartmann or you bring it as a distal mucous fistula. Now, say suppose in an elective setting, if there is evidence of like conditions like dysplasia, malignancy, refractory symptoms, despite maximal medical therapy, this is what I want to try to concentrate here. That is medically refractory Crohn's. So what you have to do is you have to check for certain things like if there is rectal involvement or not, if there is how much number of segments is involved, and if there is patient is willing for surgery or not. Say suppose there is no rectal disease, and when there are two or more colonic segments affected, yes, obviously total abdominal colectomy and ileorectal anastomosis is indicated. There is no doubt in that. If there is rectal involvement, again the same thing, medically refractory disease despite refractory symptoms, despite maximum medical therapy, what you have to do is total proctocolectomy and you do an end ileostomy rather than a segmental resection alone in case of medically refractory cons with rectal involvement. So both options are A and B are correct. Now, this is the update. That is the European guidelines. What it says is that if there is medically refractory Crohn's disease or colitis, what you need to do, you have to do a defunctioning ileostomy rather than a colonic resection, and you have to give the top-down therapy. That is the approach of medical disease. So that is, and you can observe it. Okay, and that is one form of making the medical therapy with minimal surgical intervention, thereby avoiding total abdominal colectomy. Do you understand? We are giving medical management like type of a topical therapy without avoiding maximum resection. You just try to do a defunctional ileostomy, put in all your medical treatment like top down approach, and then try to treat the colon with your medications, which is given down the ileostomy. Okay, so this is what the examiner was asking. So you can approach a medically refractory disease with the top-down therapy with antibiotics, say suppose, and you can follow it with diversion and continue the therapy is the right option. And there, this is the option where students were not able to give us exactly, but I think this is what examiner was a concept he was trying to exploit. So it is a top-down therapy with antibiotics followed by diversion, and you can continue the therapy. And if you do so, you could manage the medically refractory disease also as well as the stricturing part also without taking down the colon, that is without doing a total abdominal colectomy. So this statement is not exactly what we got, not exactly what I've given there, but this is what we got from the students. So you have to be aware. The exact statement is given in Shackelford, and it's given the chapter like surgery for Crohn's disease, where they have given detailedly about, I could say the page number also. It is like 1972 of Shackelford 9th edition, where they have explained about the European guidelines in case of medically refractory Crohn's disease, where we were following total abdominal colectomies and doing ileorectal or a total proctocolectomy and doing end ileostomy. There are latest guidelines which says in case of medical refractory Crohn's disease colitis, you can do a defunctioning ileostomy and try to give in your medical treatment, thereby avoiding colonic resection. So these were the questions, 4 to 5 questions only in the last two papers. I'm not sure. This is the we have got almost all the questions, almost 80 questions we have got. So less number of questions were asked from colon, rectum, and anus, but try to see the topics which are concentrated. It is the CA part. It is the inflammatory bowel disease part. Maximum they will concentrate either IBD, which is the most favorite topic of all examiners, as well as the colorectal cancer genetics part, and as well as the syndromes part. Okay. So until next session, let's meet in the next session. So the topic given to me contains only 4 or 5 questions. So I had no other options to take any other thing. Until next time, I sign off from here. Let's meet. All the best for your exams. Hope to see you in the other end, and keep giving us feedback for all those we can, so that we can improve in the upcoming sessions. Thank you.
Thank you, sir.